Good afternoon. This is a presentation of our longitudinal elder care services at Care for Your Health. Care for Your Health is a nonprofit that operates in Montgomery, Prince George's, and Howard counties, whose mission it is to deliver inclusive, trusted, and multicultural healthcare where care is needed, fostering autonomy and quality of life for all members of our community. Currently, the way we take care of elders is very segmented and it's mostly hospital based. As people age and are unable to take care of their health needs by leaving their house and going to the office or going to the specialist or going somewhere, they're left with no other resource that use the hospital as their home base. And as such, they become accustomed to dealing with all their healthcare needs through the hospital system. What our longitudinal healthcare services proposes is a change into an integrated longitudinal elder care system within the primary care setting, where when the individual starts receiving care, they can transition through the many stages of their aging. They can receive geriatric care as a specialty or as a consultation services to the primary care setting, and they can receive home-based care, reducing the need for hospital care significantly. As you look at longitudinal elder services, you have different stages. The first one, which is the young adult, you focus intensively on preventive and early detection. And this includes services like pre-conception care and screening and risk assessment. It looks at screening and early detection of infectious diseases, of metabolic diseases, but the focus is on keeping people healthy. As we progress in age, some of these people end up having chronic conditions, so the shift moves into early detection and chronic care management. As we move to the younger elder, which in the literature is known as the young old, we focus on chronic care and elder screening, which is a little bit different than the typical screening that we're used to. Elder screening has to include risk of falls and complications of a fall, risk of incontinence and all associated social pathologies. It looks at screening for loneliness, screening for mental health, screening for cognitive impairment. So the screenings that you need to start focusing in the younger elder are a little bit different than the ones that we do in the young adults and the adults. And a lot of times what happens is that people are like, oh, well, you only need a colonoscopy. No, we need to have incorporation of all these other screening. And finally, old or elder care includes chronic care management. The issue with chronic care management at this age is that the goals of care change. And a lot of times, what you see in the primary care setting is that there is no adaptation of goals. So, for instance, an example is that if you look at the literature, diabetes control is better managed at around 8 of hemoglobin A1C when you have old, as opposed to the 6 and the 7 that we are aiming in the younger. Blood pressure levels are okay around 140, 150 as opposed to when you're younger. So chronic care also shifts a little bit in terms of the goals of care that we have. Then we include the home-based care, and the home-based care is not only primary care, it can shift towards an end-of-life care methodology. And then you add the community palliative care program, which is really about primary care shifting to more of a quality of life approach when a lot of the chronic conditions are really advanced. Care for your health, we focus, as we have mentioned, in primary care, and we have two main service lines, the elder care and the community care. This graph is a little bit misleading because we see a lot of our patients in the community care setting. It's just that the services are a little bit more compacted. So in the elder care, we have a home-based care, and in the home-based care, we deliver primary care, palliative care, and a program that's called the hospital at home. We'll talk to you. Community palliative care, which has home and office components, and geriatric care, which is part of the primary care, but also the cognitive and dementia care. And in the community care infrastructure, we have office care, and we don't deliver care in the traditional big office with plenty of places. We have micro practices. So the biggest office has 2 examining rooms, um, and we actually have um, 2 offices right now. We are looking at partnering in Laurel to have another physical office. Um, and then we actually have a big pop-up infrastructure with 7 sites where we go either with our mobile unit or on site. And generally on site is the basement of a church, or actually we can pop up in Poolsville, for instance. We are starting a partnership with the only clinic that there is in Poolsville, and they're gonna let us use their clinic on Saturdays. So it's still a pop-up, but it happens within a clinic. So that's the infrastructure by which we deliver longitudinal elder care. We serve patients from 19 to the day they die. In terms of the quality of outcomes, these are a select few of the quality data that we measure. Um, it's very important for us to look at advanced directives, and we have been looking at making sure that both our Caucasian and black and white, black and white, black and brown patients have the same access. Our goal is 80%, which is much bigger than the majority of primary care settings. So we are getting there, but still have some way to go. But the disparity have decreased significantly. So that is an important aspect of the work we've been doing. We also have an integration of mental health into the primary care setting. We actually try to screen everybody. We're close to screening everybody for alcohol use, anxiety, and depression. These are the 3 that are most common, the ones that we track. We also screen for drug and tobacco use. And we treat other mental health diseases integrated. The way our integration works is the screening and the pharmacological treatment is done by the primary care. Complex complex patients get discussed in the interdisciplinary meeting, and if they don't improve with the common plan, then they're referred to psychiatry. For complex diseases like schizoaffective disorder, schizophrenia, psychosis, they get referred directly to the psychiatrist. And then we have, because of our elder care, we have a grief counselor that works around loss, not only death, but any loss, right? So, um, you know, for instance, the caregiver of men with dementia that used to be the stay-at-home person and suddenly needs to be the person that takes charge of everything. There's a loss of role, when you retire, no longer have that caregiver or provider of the house. So there are a lot of circumstance where grief counseling is very effective in this population. And then our main outcome, this we have been tracking for many years, and it's the place of death. 80% of our patients die at home. 10% die in inpatient hospice, and those are people who had really severe symptoms and difficult to control, and in a lot of cases, not the social support at home to support a death at home. And then we have another 10% that die in the hospital. If you compare this with the traditional outcomes in the statewide data, they're around 30% of people die at home. So we think that our longitudinal elder services are very effective in providing people the care they need where they need it. So how we look at the reimbursement. Unfortunately, the reimbursement model is not there yet. We are actually partnering with people and looking at our data to make a point. But what we need to say about that is that when we move to value-based, we are uniquely positioned to manage risk. And as you look at the healthcare system now, it is really based on, it's really based on volume. You get paid, you make money if you have volume. Whereas in the value-based infrastructure or the model, you are going to be able to be financially successful if you manage risk properly. So we think that the model offers a big opportunity to take care not only of aging populations, but also of a way of managing risk that is effective. So we are looking to the possibility of collaborating and having partners that understand the care of low-income individuals as a human right and not as a commodity. So we would be very happy to partner with you.